All right, good morning, everyone. My name is Megan Lowry. I'm a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you so much for joining us this morning for a webinar on the report that was just released titled Improving the CDC Quarantine Station Network's Response to Emerging Threats. You can now download a copy of the report and other supporting materials at www.nap.edu, and we'll also chat that link out to you. A recording of this webinar will be available on our website in the coming weeks. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from this study represent the consensus view of the committee and must undergo external peer review, as did this report. I have with me several members of the committee to discuss the report today, but before I introduce them, I want to go over just a few brief reminders. First, please note that this webinar is scheduled to last 1 hour, so we'll start out with a presentation from the committee members, and then we'll open it up to any questions you may have after they're done. To ask a question, just type it into the box below your video window, and you can submit a question for the committee at any time during the presentation. So now I'd like to introduce the members of the committee that wrote the report who are here with us today. First is Georges Benjamin, Executive Director of the American Public Health Association and Chair of the committee. Stephen Ostroff, Adjunct Professor at the University of Pittsburgh Graduate School of Public Health. Edward Ryan, Director of Global Infectious Diseases at Massachusetts General Hospital and Professor at Harvard University. Jason Wang, Professor of Pediatrics and Health Policy at Stanford University. Reuben Warren, Professor of Bioethics and Director of the National Center for Bioethics and Research and Healthcare at Tuskegee University. Ietze Borges, Professor and Researcher at the Department of Population Studies at El Colegio de la Frontera Norte. Larry Ghostin, founding Linda D. and Timothy J. O'Neill Professor of Global Health Law and Director of the WHO Collaborating Center on National and Global Health Law. And with that, I'll turn it over to Julie Pavlin, Senior Director, Board on Global Health at the National Academies of Sciences, Engineering, and Medicine.
Thank you, Megan. Hi, I'm Julie Pavlin, as she said, the Director of the Board on Global Health at the National Academies. I really do want to thank you for taking the time today to hear about our new report on improving the CDC Quarantine Station Network's response to emerging threats. Little history, approximately about a year ago, the CDC reached out to the National Academies to ask if we could provide an update to the recommendations from a previous study we did over 15 years ago, which was directed to the Division of Global Migration and Quarantine and how to improve the effectiveness of their border quarantine stations in mitigating the threat of infectious disease importation and spread. They said they found the previous report extremely helpful over the years, but with everything they and the world and all of you experienced with COVID, it was time for a relook at their programs and procedures. We readily agreed and then put together a team of experts who volunteered their time to quite rapidly put together the recommendations you'll hear about now. We concentrated on specific priority areas, although we know this discussion and analysis will expand through many different circles and many different programs as we learn more every day on the efficacy of preparedness and response to many infectious diseases, not just COVID. So we look forward to hearing your questions and comments. Please do put those in the text box there. We really would like to hear those. And we have a website, or the website will have more information. We have an email address. You can continue to send those in to us. And we thank you for that. So now I'll turn it over to Dr. Georges Benjamin, who chaired the committee.
Hello, everyone. Let me just thank you very much for spending some time with us to hear about this very important report. As chair of the committee, I had an opportunity to work with this really amazing group of folks. And so we're going to give you a little bit of talk about what this report did. If you go to the next slide. Here's our agenda today. We're going to kind of do an overview of the U.S. quarantine network and our statement of tasks, talk about the 5 core areas that we really focused on in terms of our recommendations: organizational capacity, disease control and response efforts, new technologies and data systems, coordination and collaboration, and then the legal and regulatory authorities that we think are important. And then at the end, as we said, we can take questions and ask and answers for you. If you go to the next slide, just to give you a sense of the full committee composition. Obviously, all the committee members are not on this call today, but these are 14 professionals that were involved in our study. Just give you a couple seconds to take a look at that list. And of course, you have these materials, so you can get the detail into who they are. We go to the next slide. So here was the committee's charge. We had 3 big bucket areas, even though it's a much more detailed charge in the report. First of all, we wanted to identify effective interventions and best practices in the U.S. context. We recognize there are lots of challenges that happened around scaling up, data gathering, interoperability and engagement of partners, and the policy toolkit that the CDC has. Secondly, they asked us to review how other countries, international and multinational organizations, did this in the context of us evaluating the work currently and in the future for the quarantine station network. And then 3, of course, making any potential changes to the infrastructure and regulatory authorities, as you saw in those 5 core areas that we reported on. Next slide. The quarantine station network, this gives you just a sense of what they look like. These various colors are the areas that the particular quarantine stations have in their catchment areas. And just to remind you that these stations' primary responsibility are to control infectious diseases at our borders, both our land borders and other ports of entry. So that's through maritime and through the aviation industry throughout the country. And so that's why we have quarantine stations throughout. And they do this through a whole partnership. If you go to the next slide, this next slide is actually a figure from the previous report we did about 15 years ago. I actually did chair that committee too, and there were some of the committee members on this committee who also had the opportunity to participate in that other report. But it shows you a very complex system. We know that anything in public health is a federal, state, local, private sector partnership. And this gives you a sense of what the various list of partners are, both within government, outside of government, private, nonprofits, et cetera, are all part of that network. Next slide. So with that introduction to our work, we now want to begin talking about those report recommendations. And so for the first report recommendation, I want to talk a bit about, go to the next slide, the organizational capacity. And if I could have Stephen, if you would talk about that. Dr. Stephen.
Well, thanks very much, Georges. This is Dr. Steve Ostroff. Organizational capacity refers to the sort of the nuts and bolts of the division itself. And so we looked in several different areas. One of them was the actual infrastructure, the way the division is set up. We also took a look at the finances as well as the workforce and the organizational culture. I think one thing, not only this group, but the entire committee was very impressed with the dedication and commitment of the people that do the very important work to reduce the likelihood of importation of communicable diseases into the United States. One of the other things I think the committee was very impressed by is that since the last report, this division has been in response mode to major emerging infectious disease threats far more often than not. If you look at the history, very often it's not just only one response that they're handling, it's multiple responses at the same time. And we saw this certainly over the course of the COVID pandemic. And not only is this now become sort of the normal operating state and not the exception, but the responses themselves have become longer and they have become far more complex. And I think this is important to note in terms of some of the recommendations that are being made, because one of the things that you observe, in particular, if you look at the funding, of the division over the time period since the last report is that their regular budget has been remarkably flat. In most years, there is possibly a 1% increase in the budget, and that most of these responses that they've had to deal with have been looked at as one-off, and they've been funded as though they're one-offs rather than being the norm for the quarantine division. And so what you see, and this is well set out in the actual report, is that there are tremendous fluctuations in the amount of funding and as a result in the number of personnel working in the division, with the vast majority of those personnel being temporary personnel. And that is really a challenge, not only to be able to rapidly scale up in response to the various emergencies, but of course, if it's all supplemental funding, it makes it difficult to bring on permanent staff and have some consistency over time in terms of your personnel and being able to sustain programs. And so this was a very noteworthy component of the observations of the committee. And so with that background, let me go through some of the recommendations. Next slide. So our first recommendation is that the Department of Health and Human Services, especially including the CDC, should ensure that this division has the necessary financial and personnel resources, has an effective organizational structure and an optimal infrastructure to be able to effectively meet its responsibilities, execute its ever-growing volume of work, and achieve its mission. The DGMQ needs to specifically act and resolve the following issues, and not just DGMQ, but also CDC. So in terms of the structure of the division, we believe that based on its size, being one of the larger organizational components at the CDC, both at the division level as well as at the center level, that strong consideration should be given to restructuring the Division of Global Migration and Quarantine to become a standalone unit with a direct reporting line to the CDC director. And there are a number of reasons, which we could talk about later, that this makes a lot of sense to the committee and should be strongly considered. In terms of the finances, HHS should make a special agreement with this division to enable it to be able to utilize readily accessible funding in future emergencies so that they are not waiting for supplemental funding, which often comes very late in the course of the response, in order to be able to start scaling up. That's a very inefficient and relatively ineffective way to be able to address the various emergencies that they are confronted with. In addition, because of this issue that I mentioned previously, which is that there really is a need for sustained, predictable funding, which so far hasn't been the case in recent years, that CDC should explore, along with the administration and Congress, the development of a user fee program to ensure that the division has a consistent and dependable source of revenue to cover the costs of operating the quarantine stations and the rest of the network. Next slide. As far as workforce is concerned, the division should develop and implement a comprehensive and contemporary personnel plan to address multiple issues that the committee observed regarding recruitment, retention, skills development, vacancy rates, which are increasing, burnout of staff, and excessive reliance on contract and temporary staff. The division should also develop and launch innovative strategies to support its critical recruitment needs, either them specifically or in concert with an overall CDC recruitment plan. And the DGMQ should leverage opportunities presented through CDC Director's diversity, equity, and inclusion initiatives while undergoing the division's workforce study mentioned in item number 1. DGMQ should also assess its organizational culture and climate in association with the Personnel and Development Plan to ensure that the division's values positively support its mission. This assessment should include a focus on diversity, equity, and inclusion. Next slide. Our second overall recommendation is that DGMQ should create an effective and innovative quarantine station model that matches the expanding and changing needs of a global mobile world and augments its work in a progressively challenging infectious disease environment. In other words, I think the committee felt that the quarantine stations themselves were designed for the past and not necessarily for the challenges of today and certainly the challenges of tomorrow, and that they need to be able to take advantage of a lot of changes that have occurred and use technology, et cetera, to be able to do their job more effectively and more efficiently. So to achieve this recommendation, DGMQ needs to implement specific steps. One is to develop criteria to determine whether a quarantine station should be added, deleted, or upgraded, and adjust the current number of stations accordingly. In the previous report, there was a recommendation to expand the quarantine network. In this report, the committee does not make specific recommendations regarding whether there should be further expansion or whether or not there should be contraction to make sure that there's adequate staffing. The one thing that the committee did feel very strongly about is that we don't live in a world that operates on a 9-to-5 schedule. And right now, the quarantine stations are staffed for 9-to-5 functioning for a 1 shift a day. And the committee felt very strongly that they need to operate at least 2 shifts a day, and certainly in emergency circumstances around the clock. And they are not adequately staffed or structured to be able to do that. Secondly, the committee feels strongly that based on the experience of the pandemic, that there should be a permanent maritime unit to be able to deal with the cruise industry and to deal with other maritime circumstances. Right now, there are 2 separate entities at CDC that work with the cruise industry. One of them is DGMQ and the other is the Vessel Sanitation Program. We think it would make a lot more sense for there to be a unified voice in terms of working with that industry. And so a recommendation was made to create a permanent maritime unit to be able to accomplish this. Third, to develop a more robust program for pre-clearance of passengers, immigrants, and animals. The idea here is that instead of waiting until people arrive in the country, that there are certain things that conceivably could be done more effectively and efficiently upstream before they board planes or before they board ships to be able to keep things out in the first place. And lastly, to redesign post-entry follow-ups in partnership with local and state agencies and other federal agencies using modern technologies to make this handoff much more efficient. Next slide. Thank you very much. I'll turn it back to you, Georges.
Thanks, Steve. Let me now turn to Dr. Edward Ryan to talk about disease control and response efforts. Ed?
Dr. Benjamin, thank you. So my name is Ed Ryan, and I have the honor of chatting with you today to give you a summary of the full committees and the disease control working groups' thoughts on disease control and response efforts. The committee had 3 recommendations, and we'll review them in a second, but it's worth giving some context to this area. The first is, in many ways, the disease control and response efforts are the meat of what this division has been charged to do. And it's worth spending a second thinking about how broad that mandate is. This division is charged with trying to prevent or limit or mitigate the introduction of infectious diseases into home communities in the United States. And when you take a step back and think about that, it's extremely broad and it's extremely variable targets. For instance, as Dr. Ostroff mentioned, this division has basically been in response mode continuously for over the last decade. And although we're all well aware of the recent SARS-CoV-2 COVID-19 pandemic, it's worth taking a step back and remembering the litany of infectious pathogens that this division has had to respond to over the last 10 years or so. And in no particular order, that includes Zika, chikungunya, and dengue for vector-borne diseases, a number of food and waterborne outbreaks, contact illnesses that are transmitted by contact, such as monkeypox, which has been probing at the United States repetitively now over the last 10 years or so. Ebola viral disease out of West Africa, which is probed a number of times as well. H1N1, pandemic influenza from about a decade ago, and SARS-CoV-1 and Middle Eastern respiratory virus, or MERS, out of the Middle East. So, and that's just a short and incomplete litany of some of the things that this group has had to respond to. Recognize also this group is charged with protecting against diseases of human importance, and that those can be transported not only by humans, but also by animals and by items. And that would also be under the charge of this group. So next slide, please. So the committees with regard to this, recognizing the wide range of potential pathogens that this group needs to respond to, recognize that each of those individual pathogens are unique. They might have different incubation periods. They might be transmitted via different routes, whether respiratory or vector-borne or food and water-borne or contact. They might have different treatment capabilities. They might have different diagnostic capabilities. They might have different symptomatic to asymptomatic ratios, making it more or less likely that an infected individual would be recognized, et cetera. So there's many details that go into trying to come up with response plans. And so the committee, with all that as context and background, the committee had three recommendations in this regard. In the first recommendation, the committee recommended that the division continue to develop and explore their detailed operational plans and playbooks, especially for what would be considered the most common or most repetitive infectious disease threats that the U.S. home communities have faced. This would be akin to sort of what the Department of Defense has with regard to potential operational plans for given scenarios. And the committee suggested that the division continue to develop these plans and playbooks, especially in light of their complexity and especially in light of their need to partner with state and local and private partnerships among many other individuals. And such operational plans would allow the recognition of which partnerships need to be further developed and what might be some of those aspects. With regard to which pathogens to identify and to develop continue to develop operational plans for, the committee suggested that the division continue to work with a wide range of partners, including those in the epidemic preparedness divisions at the CDC and the CDC Center for Forecasting and Outbreak and Analytics, and the CDC Center for Public Health Preparedness and Response, among other partners. Next slide, please. Next slide to 3.2. Perfect, thank you. So the second recommendation was a recognition that, as we talked about, each of those infectious threats is unique in its own way, and they can be unique with regard to scale as well. So recognize this division is charged with everything from helping an individual with a single individual with a highly with an infection of high public health consequence. I'll give an example: somebody with highly drug-resistant tuberculosis, and scaling all the way from there through families, through populations, whether immigrants, refugees, whether groups of individuals coming from different regions of the world, all the way up through everybody, as we see with the current pandemic. And what the committee recognized is, as you move up that scale, that the toolkits that this division has need to be scalable. And as such, especially with regard to large-scale isolation and quarantine and large-scale responses like we're currently seeing with the current COVID-19 pandemic, the committee felt that there's going to be some very important lessons learned from this most recent scale-up, and then those lessons should be looked at in detail, and there should be operational plans put in place to assist with large-scale isolation and quarantine if required for future infectious threats that are widespread going forward. And the committee recognized that this would require all different aspects regarding clarifications of legal authority and enforcement, and we'll hear from Dr. Gostin on that in a few minutes, as well as the logistics involved with these large scales, and the aspect of these large-scale issues requires special partnerships with other agencies and groups, including law enforcement, emergency management officials, et cetera. Next slide, and the last slide, please. So if we can, perfect. And then the last recommendation from the infection control and disease response subgroup was that there's been enough water under the bridge now and enough variation in the different responses that this division has had to do, that there should be formal external evaluations of what worked and what didn't work, and what might be some of the things pointing to the future of which tools should be used and when they should be used. And the committee thought that two pertinent examples might be the response, the division's response to the Ebola outbreaks about 7 or 8 years ago, as sort of a medium-sized outbreak importation into the United States, or response into the United States, and compare that also with the COVID-19 response that the division has been involved in. And the committee felt that this evaluations and modeling should look holistically, not just at number of cases, et cetera, but also some of the consequences of use of some of the tools that were deployed and used. And the hope here is that such evaluations would allow the division to recognize which of their tools are most significant and most impactful during different threats, and to identify metrics of when those tools should be used or rescinded. And with that, I'll stop, and I look forward to questions at the end. Thank you.
Thank you, Ed. So I'd like to now go to Dr. Jason Wang. Jason.
Hi, this is Dr. Jason Wang. As Dr. Benjamin has alluded to, because of how fast the virus has spread during the COVID-19 pandemic, we really needed to take advantage of new technologies and data systems in order to scale and to gather data. And to do that, we also need to make the data systems interoperable so they could talk to each other. Next slide, please. So the committee has 3 recommendations with regards to technology and data systems. The first is that DGMQ should increase and improve the use of innovative technology to aid in outbreak detection and response to mitigate disease transmission. And so during the COVID-19 pandemic, new technologies have emerged, such as CRISPR, which sometimes allows a detection of over 1,000 samples and close to 200 different viruses. And also wastewater detection of viruses that allows communities to be monitored over time. The DGMQ should improve readiness and develop flexible and targeted strategies for disease control at the border. The DGMQ should incorporate and improve the use of digital technologies to gather health data from travelers, trace transmission, and alert travelers to exposures. And some of these digital technologies actually have been deployed in countries such as the UK through the NHS system, and have been shown to actually allow faster detection of people who are infected with the virus. The DGMQ should support the adoption of the Office of the National Coordinator for Health Information, UNC, roadmap by healthcare and public health practitioners. The DGMQ should work with the UNC to facilitate the UNC roadmap and interoperability networks. As health information technology developers continue to increase functionality in mobile health applications and electronic health records, the DGMQ should identify gaps and opportunities in legislation and regulation to support the proper use and transfer of information across data systems. This particular recommendation is about interoperability, that there needs to be common standards such as the HOA, FHIR standards that allows application program interfaces, the APIs, to connect different data systems so that they could talk to each other and allow faster analytics for the detection of viral spread. Next slide, please. The DGMQ should ensure that all users of digital technologies, novel data systems, streams, and interoperative public health information systems follow a careful consideration of their ethical aspects, and that all actions are in accordance with existing regulations for the protection of personal data. And this is particularly important to ensure that privacy and governance is in place. In order to achieve this, the DGMQ should put an oversight structure in place. And so again, this is the governance of data. When we try to collect from the population, that needs to be carefully considered. I'll turn it over back to Dr. Benjamin.
Thank you. And now we're going to move to coordination and collaboration. We have two of our colleagues who are going to present here. Dr. Litsa Bodekwets, followed by Dr. Ruben Warren.
Thank you. It's a pleasure being here with you today. So I want to start speaking about coordination and collaboration. This was a component of the report that was led by Dr. Ruben Warren. And the first thing I want to say is that in order to fulfill its mission, in order to accomplish its mission, the division needs to collaborate constantly with different partners, both within the United States and internationally. So this is a very major aspect of the division's activities. And what we tried to do was to provide some suggestions about what could be improved in that sense. So next slide, please. And given the situation with the COVID-19 pandemic, we took advantage of the lessons learned during the pandemic, and we tried to highlight the importance of international collaboration within the framework of the existent norms, regulations, agreements, etc., and also of the new things that could be developed in this regard. So the first recommendation was that the DGMQ should strengthen partnerships through define and plan activities that enhance working relationships and continue to build trust. And to do so, we had some specific measures that we suggest should be taken by the division. The first one is about improving collaboration with international partners through regularly scheduled forums. So I want to speak first about the International Health Regulations, IHR. The International Health Regulations are an international agreement between countries that helps or tries to provide a better response, detection, reporting, and response to public health events of international concern. And it's led by the WHO. And since the COVID-19 pandemic, there has been multiple efforts to review and adapt the international health regulations to the new situation that was brought forward by the pandemic. And the CDC has actually been quite active in this discussion. And recently, in the last meeting of the World Health Assembly, there was an agreement actually to review, to a roadmap for reviewing these regulations. And what we are advising here is that the division has a major part to play within this discussion, given its relationship with many international partners. And the second aspect is directed mostly to the binational collaborations in the land border areas, which are needed to facilitate the development of trust between partners. So trust is a very important component of collaboration. And there has been over the years many initiatives of binational collaboration for public health promotion, detection of threats, etc., and response. And participating with other agencies and partners in the development and implementation of harmonized approach to border measures is very important in order to better respond to future threats. And with that, I send it over to Dr. Warren. Next slide, please.
Thank you, Dr. Bodekwets. As you've heard, CDC has long-time relationships over many years and much success. Our group specifically focused in on the coordination and collaboration. We represented an interdisciplinary group of colleagues from various federal, state, local governments, the academy, healthcare, and health professions. Continuing the recommendation, we wanted to improve coordination between federal, state, tribal, local, that is county and city or territorial health agencies and strengthen international collaboration and engagement of quarantine officers. Under B, we want to develop a federal interagency work group with input from STLT partners. 2, strengthen isolation and quarantine preparedness planning. And 3, ensure pre-decisional input and engagement from STLT health agencies. Under that recommendation as well, C, to improve coordination with aviation and maritime industries for border traveler health issues and mandates. Under C, build a coordination mechanism established during the COVID-19 pandemic between aviation and maritime industries with STLT health agencies and the DGMQ. And 2, to improve DGMQ engagement with regulated industries such as cruise partnerships. Next slide, please. Next slide, please. Our second recommendation, the DGMQ should modernize health communication efforts with and for travelers to improve public understanding of disease control efforts as well as compliance. Under 5.2, A, develop standardized communications for travelers, families of travelers, and the general public. B, establish mechanisms to utilize airline, airport authority, and travel agencies to communicate messages and better inform travelers during a pandemic, emerging pandemic, or outbreak. C, collaborate with the aviation industry to provide pre-departure education and information sharing prior to flight boarding and during ticket purchase. D, to incorporate avenues for DGMQ to share information material with travelers. And E, in order to avoid health inequities, make these communications accessible for all travelers, regardless of language, access to technology such as smartphones, disabilities, and so on. Next slide. Thank you so very much. Dr. Benjamin.
Thank you. And let me just now turn to Mr. Larry Gostin to talk about legal and regulatory authorities. Larry.
Thank you very much. I'm Larry Gostin at Georgetown University. I wanted to just start by thanking Dr. Georges Benjamin for just incredible chairing of the committee. Tiquam and the staff have been extraordinary, and it's been a real privilege to work with my fellow committee members and with the staff at NASEM. I want to talk a little bit about the legal authorities because throughout the COVID-19 pandemic and well before the COVID-19 pandemic, CDC and this particular division has been responsible for most of the regulations that have emerged in the past, whether it was multi-drug resistant tuberculosis or Ebola or other diseases. The quarantine regulations of the division were very active. The only difference, or the major difference during the COVID-19 pandemic is that the regulatory functions of the division were of a vastly greater scale. The United States has never witnessed, in at least in our generation, a health emergency of this magnitude. And so CDC, through the division and elsewhere, put forward a number of regulations that were science-based and intended to mitigate spread of SARS-CoV-2. We saw that in its do not sail and other regulatory orders of cruise ships in the maritime industry. We saw it with masks on public transport, Title 42 at the southern border, housing eviction moratorium, just to name a few of the key regulatory actions that CDC took to try to curb transmission. As you've heard, and from a legal point of view, it's quite important, but under the Constitution, CDC's regulatory functions are not necessarily to reach within a state, but to prevent interstate and international transmission of a dangerous infectious disease. So CDC acts when any given state acting alone cannot curb the risk. And so you need a uniform national standard to protect against the introduction of infectious diseases at the border, for example, through travel restrictions and bans, either targeted to particular countries or general ones, and within the country, from state to state. Most of these powers are exercised through the Public Health Service Act of 1944. That's an act that gave CDC apparently quite extensive authority. It lists a number of actions that CDC can take, including sanitation and inspection. But then it also goes on to say, and any other measure that CDC deems necessary to protect against interstate or international transmission of a dangerous health threat to the United States. But since 1944, there's been a considerable tightening of scrutiny by the federal courts of these kinds of actions. And I think it's fair to say that virtually all of CDC's regulatory measures at one time or another were either delayed, many times significantly, or blocked by the judiciary. One current recent example, of course, is the CDC's transit mask mandate. We saw that a federal district judge in Florida ruled that the mandate was unlawful and not authorized by the 1944 Act, focusing on the term sanitation and saying that masks were not part of sanitation. CDC requested, and the Department of Justice agreed to appeal that, and that's going up to the 11th Circuit. And so if I can get the next slide, please. Is that going to come up? I guess not. Okay. I will carry on then. Here we go. Recommendation 6.61. So we made the recommendation as a committee that Congress should improve the legal authority and flexibility of the CDC in responding to public health threats. And we recommended modernizing and improving the 1944 Public Health Service Act. We did that recognizing the political context in which that recommendation is made, where there's considerable division in the United States Congress. But we thought that the fact that the courts were requiring modern and very specific delegations of authority, that this was important to do. And so first, well, I guess the slide is not up yet, so I'll just take it up on my screen. Let's get it here. First, we argued that the spread of that CDC's powers should be strengthened to give the authority to effectively prevent and mitigate current and future public health threats. CDC should have the authority it needs, but it always has to act consistently, and we believe that it has done so with scientific evidence, and only where necessary to prevent interstate or international spread of infectious diseases. Specifically, Congress should delegate power to reflect what the CDC needs to carry out its mission through evidence-based measures. The delegation should provide CDC with robust authority and necessary flexibility to implement these science-based public health measures. We also recognize that the United States has changed since 1944, and the importance of individual rights and freedoms, including procedural due process of law, have become extraordinarily important, and they're important in our minds as well. And so we recommend that CDC and that the statute include protections for individual rights and freedoms and procedural due process where it's constitutionally warranted and feasible. And then finally, that CDC exercises authorities fairly and equitably. The committee recognized that there was considerable inequality during COVID-19. And we wanted to be sure that when CDC acted, particularly when it acted in a regulatory sphere, it did so clearly having in mind society's most vulnerable and marginalized populations, and to exercise their authority in a fair, reasonable, and equitable manner. So that is our recommendations. And I would just simply conclude by saying that when the lesson learned from COVID-19 is that when the next public health emergency strikes, we want to have a CDC that can act flexibly, nimbly, and decisively, but also equitably and fairly, and respecting the rule of law. So thank you, and I'll turn it over to our chair, Dr. Benjamin.
Thank you. And I'm going to take it back to Megan to manage the Q&A. Megan?
Great. Thank you all very much for that presentation. As Dr. Benjamin said, we're going to open it up for questions now. So as a reminder to our audience, to ask a question, just type it into the box that's right below the video player on the webpage. I think we have a few additional committee members joining us who did not present but are here to help answer questions. So I'll just invite them to turn on their cameras if they haven't already, and a reminder to them to introduce themselves the first time they answer a question so the audience knows who they are. All right. So our first question today from the audience, many of the technology tools for contact tracing and exposure notifications are limited by the various personal privacy protections the federal government has in place. And often these technologies require the individual to opt in. While these are used widely in other countries with different governmental structures, how can DGMQ best implement technology solutions within these limitations of our government's legal privacy protections?
Well, yeah, Jason, why don't you take that, and then I can comment after.
And I can also add some of the legal side if you wanted me to, Georges.
Sure.
Excellent question. I think the question is started by that many of these technologies are opt-in. So it's important for people to have a choice of opting into this technology. And in fact, that was the case in the UK through NHS. When people have the option to opt in, over 50% of the people actually downloaded the app, and over 70% of the people, when they contracted COVID, they actually reported through the platform. And it has been shown that for every 1% of the people downloading the app, there's a 1% decrease in the cases in that region, and that was published in Nature. The choice for individuals is very important. The second thing is outlined in our recommendation is that there needs to be a governance structure. Experts such as Dr. Gostin and others, ethicists, looking at really legality of these new technology and the given ethical considerations to them with a governance board. I'll turn it over to Dr. Gostin.
Well, let me do one thing before I go to you, Larry. Just remind everyone that these technologies actually developed as we were going through the pandemic. So in effect, we were building them while we were flying. And I think the first thing if I was to recommend to the I think the committee would agree, is the first thing they need is a strategy. We have a series of really new emerging technologies. Let's put them on the table. Let's look at what's there. Let's look at what's in the future. And actually build them as part of a comprehensive plan on how best to utilize them. Once you know what you want to do and how to do it, then you can put in performance times, turnaround times, and create a system using these technologies. And as you know, one of our recommendations is that they sit back and look at some of the research options that they have. They can also build that into their research model for some of these technologies as well, which allows for some early use, user authorization to use the technologies, and figuring out new ways to engage people as part of that. So that I want to add that kind of as an overlaying way to approach that. And then Larry, if you would talk about the legal aspects of that, I would appreciate it.
Yeah, thanks, Georges. I think your point, Georges, is excellent, really. The truth is that we didn't have a comprehensive national plan for the use of these digital platforms. And if you think about the questioner was about location apps, but there were other apps that were used to verify vaccination status. And so you had a number of different private sector companies putting out these applications. You had states like New York State that did it. And throughout the pandemic, there wasn't any, clear technology guidance from CDC or elsewhere about how these applications could be used. I think planning is very important. There are two issues from a legal point of view, and then I'll just make another point. One of them is that if the person opts in affirmatively, then they need to opt in understanding what privacy protections they have or don't have, and so that you have a clearly informed decision by the consumer to make that choice. The other is that under HIPAA, these are not necessarily medical data, and the fact that the person is opted in suggests consent. And also, under HIPAA, there is a public health use exemption, so that it's used purely for public health purposes by a public health agency. And so that's a lot to understand. On these digital apps, one of the issues is do they have location tracking, and what is the entity that's collecting the data going to do with the data, and who will they share it with? Those are the kinds of major privacy concerns that I think the American public would expect to understand.
Great. Thank you all for those responses. It looks like we have time for about 2 more questions. We're about 5 minutes away from time here. The first being, did you make recommendations specifically for CDC's animal importation programs? For example, the dog importation program to prevent the reintroduction of canine rabies virus variants into the US. If so, can you discuss some of those recommendations?
Ed, if you want to maybe take that, we didn't really focus specifically on those, but we use those as an example.
Yeah, the committee did note that as alluded to, did note that there are other aspects, including relating to animal aspects, and there's an interface there between USDA and other agencies as well. Within this program, within this division, is not all animal-related aspects, but those animal-related aspects that are pertinent to human diseases, such as rabies. The committee did not have a specific recommendation regarding removing that or changing that. The committee did note that in the personnel that support this division there are a number of veterinarians who run the veterinarian branch, the zoonotic branch within the division, and who are the points and expertise to assist with the rabies screening program and related programs as well. So the committee had recognized the importance to humans of such infections. The committee didn't make any major changes to that structure.
May I add one thing under the organizational?
Introduce yourself, Michelle. Thank you.
Sorry, Michelle Berry from Stanford University. One thing that the organizational group did recommend is that there be a 24-hour shift at quarantine stations. Right now, due to the lack of retention or turnover, there is not 24-hour coverage at these quarantine stations, which is particularly relevant to animals coming in.
Great, thank you both. Our next question is...
Can I just add one last thing? So in one of our, this is Steve Ostroff, in one of our recommendations, we did very specifically say they need to develop a model for a model quarantine station structure. And as part of that, developing that model, I think it's important that they look at all the various things that the quarantine stations currently do, try to prioritize them and say which ones should be prioritized, which ones shouldn't, and whether or not there are other options to get those things done.
Thank you. All right, looks like we have time for one more question. So what do you think the role of other stakeholders within public health can be in implementing some of these recommendations? What do you want other public health personnel to be thinking about as they read your report over the next couple of weeks?
Let me start by just saying, I think one of the things we want to make sure they do is read the report very carefully, think about what their role is here, and then figure out how to do regular partnerships with the center. A lot of those things that happen, a lot of the engagement that happens with the center occurs on an episodic basis. And we think that by partnering more regularly, so people aren't exchanging business cards as soon as a disaster happens, I think would benefit everything, and also helping build the system on an ongoing basis and be part of some of the modeling discussions, et cetera, with the center. Anyone else?
Yes, this is Reuben Warren. I think that's one of the emphases that we engage in our group, the coordination and the collaborations. If you have relationships, both formal and informal, with CDC, try to revisit them and institutionalize them. I think that'd be critically helpful.
Yeah, and I'd just like to second or third that, is Bradley Dickerson. Much of what the committee found is that while CDC has a good bit of authority and a lot of responsibility, they still need to work through partners. And so both the federal partners, the state and local partners, tribal, territorial, all very, very important to make this system work. That DGMQ can't do it by themselves. So the importance of engagement and partnerships is, can't be overstated.
Great. Well, unless anyone else from the committee has anything to add on that last point, it looks like we are out of time. So thank you to everyone in our audience for attending today. We appreciate your time. Thank you for asking wonderful questions. It's the first of many important discussions on this report. Once you exit this webinar, you'll be redirected to our report page. You can download the report for free and in full. So with that, I'd like to thank our speakers and thank you all again for joining us today.